Hello and welcome to another edition of Empathy at the Table. And here we are with Joe Dando. Now, Joe's a really interesting, and when I say interesting, I really mean an interesting character. He's got a great story. He and I met in the gym, believe it or not, and we trained in the same gym together for about 6 months before we actually began talking to each other. And as he began talking, he started to share his story. And it's an incredible story, and the skill set that he's built up and he uses today to fuel his passion is incredible. It's a great story. Jonathan, Joe, welcome to Empathy at the Table.
Thanks, Tony. Now to disappoint your audience with a less than impressive story. No, okay, so basically the rundown is after university, quite some time ago, where I was an undergraduate in biophysics, I decided to go abroad in my job straight away. Ended up working in Vienna in Austria for Novartis, who then moved the whole department across to California. So this was in the early 90s, 1990s, not 1890s, okay, when the internet was just starting to boom. And then as my career progressed, and I moved back to Europe to do my doctorate in Milan, in gene therapy, and then a postdoc in Paris, and then really transitioned into international project management in healthcare and research and development. And at that point, I thought I'd been recruited by the French National Institute of Health, so INSERM, into their tech transfer company called INSERM Transfer. It was very small at the time, to basically work on the new European Commission projects that permitted dedicated project and program management teams to participate. And I think one of the reasons why they recruited me was twofold. A, everything had to be written in English, and being a native English speaker, that was helpful. And B, because of my international experience, again, there's a certain level of understanding how international collaborations work in research and development, especially in the translational component into clinical care. Following that, I started my own company with a major focus on rare diseases, which is an area I've been working in and around since pretty much the start of my career, with HIV, then into immunodeficiencies and rare cancers, and then a transition into pediatric neuromuscular diseases, and end up working with some really important people in the field in developing new therapeutics and diagnostics. And it ends up becoming a passion. You start really integrate in with the rare disease community, which is slightly different to, I think, a lot of other high-tech or research-based organizations, ecosystems, if you like, and I'll digress into that in a second, the reasons why. And it becomes a passion. And anybody who works in rare disease will tell you that you do this because you love doing it. You want to see an impact for all the people around you, not just the patients, but the caregivers, but also you want to see the fruits of some quite high-risk innovation as you transition into something that's going to help a lot of people. And I'll come back onto the digression of why the rare disease ecosystems are so unique. A rare disease patient typically at the highest frequency is about 1 in 2,500. At the lowest frequency, so in something like papulosis, so especially the malignant atrophic, there are less than 50 patients on the planet. What this generates inside the community is quite a tightly knit pattern of stakeholders. So we're talking the charities, which are typically the central cog in most rare disease ecosystems, because they've really got their finger on the pulse of everything that's going on around, to the research development, the clinical teams, the patients, the caregivers, policymakers, and then the high-tech innovators themselves, the small companies into the large companies, and then the hospitals. And everything's got to align. And it's one of those rare ecosystems where if any stakeholder loses, it doesn't work. It's got to be a mutual win across every stakeholder. And the other thing is, we don't say that, even though they are approved by regulatory bodies, the general phrase is products in rare diseases are elected, not approved, because the caregivers and the patients have got to see a real benefit. And the reason for this is that when you've got such a low frequency disease, you're forgotten. You're not economically viable as a target for clinical development. And that's understandable. Research and development is very high risk. There's a massive possibility of failure and a even greater possibility to not make any return on your investment whatsoever. And the economics of this means that even in frequent diseases, it can look like the companies are burning their money. So it really is a context where if you don't get it right from the start and get everybody on the same sheet, it doesn't work. And to date, you do get targeted innovation, but one of the better ways that you see large pharmaceutical companies doing it is they will have a therapeutic that's been approved for a frequent condition, and they've identified there's an underlying common mechanism which permits them to reposition that therapeutic for the patient. Go on in.
Joe, yeah, I mean, a couple of things I want to pick up on. First, I want to give the listeners a sense of actually who you are. I think that the thing that you and I connected on is you've explained what you do in a very scientific, logical manner. But you as a human being, we connected because you've got such a caustic, sarcastic sense of humor that I love it. And so as you're telling your story, in my mind, I'm thinking, you're talking about aligning all of the stakeholders, ensuring that stakeholders are aligned around in this tightly knit community. How does someone like you, who, as far as I'm concerned, you grew up as tough as nails. I mean, I've seen the way you train in the gym. You're a hardcore trainer. In the gym, you're there before I am. You leave. I leave before you do, and you've got through half of your workout. So I'm trying to get a sense of that kind of upbringing that you've had, the kind of personality that you've had, or that you have. How does it find its way into the rare diseases healthcare community?
Okay. Yeah. Okay. I mean, I've got two older brothers who are significantly larger than me and have been for most of my life. We're all quite old now, but as you can anticipate, when we're living at home together, yeah, you have to toughen up a little bit, to be honest, because you fight a lot. But that's not that particular aspect. I think it's just, kind of my own personality. It's I was fortunate enough to, have quite a strong family base, even though, parents separated and divorced. There was always felt like that whatever I wanted to do, they were never going to say no. So that was the aspect that if you have got a strong support beneath you, opportunities are easier to try and go towards. And then there's just, I think, also a sense of adventure. And we're talking about the changing in countries and learning new languages and learning new cultures. There's an aspect of you've got to be motivated enough to jump in with both feet in something that you're not familiar with and just start afresh. And I will give you a very specific example of this. I moved from California to Milan when I started my doctorate, and it was February, and it was 27 degrees in California, and I arrived in Milan, and it was -5 and foggy. I spoke 3 words of Italian and didn't have a clue of how to get around. I won't say you harden up, that makes it sound tough. If you're motivated to challenge yourself with adventure, then you're strong enough to push yourself through whatever challenges come through that. In the context of how that translates into my profession, it's a bit of yin and yang, if you like. I'm going a bit Buddhist here, but it's a case of when you're working in large-scale collaborations where they are literally on opposite sides of the planet and different time zones, and they've got 1,000 different things going on in their agendas, and you've got to try and bring them together on those small moments for cogs. You've got to have one component of your personality, which is just make it happen. You've got to just, whatever it takes. 7 days a week, it's Sunday morning at 3 o'clock. If that's the only time an Australian clinician is available, you get in the call, because it's not about you, it's not about them, it's about somebody else. But then also the recognition that, especially in a field that I work in, which is fundamentally altruistic, and we have some pretty big egos in my field, mine as well, but your common objective is something very gentle, and the best way to, I think, experience that is either you have a member of your family that's got a rare disease, or you go to a patient project meeting, which are organised by the charities, where they bring together the innovators, the doctors, the parents, the children, their siblings, who in many cases are carriers of the disease if it's genetic, but not demonstrating any symptoms or any pathogenesis. And it's you learn humility. So you've got to be hardened, and you've got to be hard enough to look through the brutality of the fact that these people are also forgotten. That makes it seem like nobody cares. They do care. It's a case of you only got a limited amount of resources, but it's a case of these people are living a day-to-day life that you've got no idea about. They are the unseen in many cases. If you have a physical disability, just try and go for a walk up the hill. And you can see this on a lot of the patient charity websites where caregivers have given how we prepare for taking my daughter for a day out. It's a 3-month run-up just to get everything coordinated so they can go for a walk up the hill. That you and me think, okay, let's just go for a walk in Colsarol, and we'll make that decision in 20 minutes kind of thing. So their life is very different. And you've got to be incredibly considerate. You can't be brutal with them. But to get it going, you've just got to, you've got to push. You have to grind. These professionals you work with, they have a limited amount of times.
The reason I really wanted to talk to you on this podcast, actually, Joe, was because of that. Because you display a perfect blend of, tough as nails, right? I never forget the day. I never forget the day I walked into the gym, and I had a hoodie on, and it was pretty cold. I think it was about November or maybe even early December, and I had a hoodie on, and I walked in, and you said, you called me a name, and you said, "You big wimp, what are you wearing a hoodie for?" I mean, train with a t-shirt, and I've never worn anything other than the t-shirt to the gym.
Oh, no.
And this is what I admire about you is that you've got that blend of real toughness. You take no nonsense. Some of the conversations we've had, you're very quick to share your opinions on things that just piss you off. Yeah. But yet you're in a business that requires you to be very considerate about other people, especially as I'm sure we'll come into the work you're doing in women's health as well. That's another thing. So, how do those two sit together inside you?
Oh, in conflict. Because in the case of there's the general component of you got to get it done, and then there's a general component of you want to be considerate and kind, and then like in any part of business, when you hit when you hit the grind, when the tube and pine, there's a dotted line, a threshold where it's a grey area, and this is a technique that you learn, at least I learned from being involved in the large scale collaborative project. Count to 10. If you haven't calmed down by counting to 10, count to 100. And keep counting. It's not about you, and it's not about them. And I think one of the hardest things for a human being today in the level of empathy is to recognise that somebody maybe is not having a great day. And whereas before, it was okay to demonstrate you're not having a great day, we've gone through it, and it might be the things I vent about when we talk. But now we're in an area where at least, for the past possibly 15 years, you must only ever demonstrate yourself to be a perfect human being. You can't go out and say, I'm having a bad day today. And you can't even articulate that because you're not going to get empathy back. We're actually living in quite a brutalised world to some extent, where in certain circumstances, people see it as an opportunity to try and score points off you. So I think it forces everybody to come out a little bit defensive. And so it's one of the reasons why, if you look on LinkedIn, you don't see a lot of clinicians using LinkedIn. It's not an area they want to even get involved in.
Why is that?
Because of that. It's brutal. And LinkedIn is probably the least brutal of the social media platforms. But it's point scoring. It's the uptick. It's the looking for attention. It's not how we operate. We have our own mechanisms of peer-reviewed articles, presentations, validation away from social media that we've had, for hundreds of years in the context of scientific publications and how knowledge and theory evolves. I mean, you're starting to see now that there's a necessity to connect taxpayer-funded research to the public. So in articles, you will see when you submit, you have to also submit a general public paragraph And in LinkedIn, you're starting to see leading clinicians post articles which they think are pertinent or relevant. And you're seeing a lot of that in neurodegenerative and mental health-based research.
So, when you mentioned about the that people in your field tend not to like social media, but when you're publishing your articles and your research and getting peer reviews, isn't that a type of kind of intellectual point scoring as well, but just in a different arena?
Absolutely. I mean, we have our own we like you mechanism and we don't like you mechanism.
Right.
Social media one is a case of not adding any value to how we already demonstrate we don't like you.
Yeah.
You know what I mean? And that sounds very brutal because you're sort of drawing parallels, but we're not that brutal. We have a very elegant way of putting down another scientist. It normally involves sitting next to them and having an argument over a bottle of wine.
So that's where your caustic humor comes in and your sarcasm. It helps you there, right?
Yeah, I mean, when I was actually living in Vienna, I went in for surgery for a minor reason, and one of my friends who was a medic gave me a book called The House of God, which is based on a hospital in LA. And you actually realise that in healthcare and research, we rely a lot on black humour to stay sane.
Oh, wow.
And so when I was doing my PhD in Milan, I was in the haematology
So
unit.
when you say black humour, are you talking about humour that black people share, that kind of humour?
Yeah, that's right. That's my personality. No, but you know what I mean? It's dark humour to cope with it. And I'll give you an example why. It's a case of, so in the haematology unit in Milan, part of the unit is working in the BMT, so bone marrow transplant. And you're dealing with children who've got leukemia, who are 9 years old. You're working this close to death.
Yeah.
And it takes a huge toll on your personality. So the nurses and the doctors typically get rotated out every 6 months to go and work somewhere else in the hospital just to get themselves out of their own depression. It's really, really tough work.
Yeah.
And you sort of, you sort of do cover that with just finding ways to stay balanced in your own head. I mean, there are certain aspects in my postdoc studies which I'm not going to go into detail on, which sent me into chronic depression. And actually went home on the weekend, actually just crying my eyes out, because what I've been working on was really end of life, and it wasn't what I was prepared for at that particular moment in time.
Yeah.
And it really does a lot of damage if you're not really prepared for it, kind of thing. So,
I mean, we joke about this, Joe, but it is a serious topic. I've interviewed a hostage negotiator, and he tells me stories of where he's literally had to go in and negotiate for families whose children or whose partners have actually, they've been killed, and he's had to look these people in the eye, and he has to desensitize himself. I think, well, how can you actually go into that world and then come back into this world and function effectively? So what you're saying, I mean, as I said, we joke about it, but there is a very, very serious element to people in your circle. And so how does this affect the way you interact with each other in terms of showing each other empathy and build trust?
I think actually we do a pretty good job of being quite considerate towards each other, because we live in a particular field. I mean, we live and work in an area where there's not enough people, there's not enough money, there's not enough assets. You're not going to save everybody. Everybody is doing everything they can with 10% less resources than they actually need. There's no point in being that angry with somebody unless they made like a completely stupid mistake that was totally preventable. No, there's no benefit. You don't gain anything. It doesn't progress what you're trying to achieve.
You mentioned to me, I remember you said about the people in your industry, because it's so highly regulated, that has an effect on the way you guys negotiate with each other, the way you trust each other. Can you share a bit about that?
Yeah, I mean, when you go through the product life cycle of development, when you're in the early stages, there's a lot more dynamic of testing new theories, testing new ideas, which basically goes into a funnel. as it gets closer to the human being. And as soon as you get closer to the human being, it becomes very regulated. It becomes very regulated in how you structure your testing, informed consent from the patient, also how you communicate externally. We've got very strict regulations on what we can and cannot say. If you're going to communicate any medical information to the general public, you must have the data to back it up. You can't just throw out an empty promise kind of thing. And so when you're actually dealing and working in that field, you're always keeping your eye on the longer term view that as you progress and transition into human care as opposed to experimental design, it does become not stale or less dynamic, but a lot more considered of exactly what you're trying to achieve. Because on the other side of this is a human being. And you do go through this phase of, are we sure we're doing the right thing? Have we made the right decisions? Is this the right group? And beyond that, there are bodies outside of how we operate that are constantly monitoring us to regulate and say, yes, no, this has changed. The classic is an adverse event. Whenever you're doing a clinical study, any adverse event you have to report immediately.
Yeah.
So that basically everybody knows that this is a possibility that there may be unnecessary suffering.
Yeah.
You've got to bear in mind that all doctors and nurses, not PhDs like myself, but MDs and all the certified nurses, their first role, their first mentality is do no harm. Do no harm. It's one of the reasons why the pandemic was so difficult. If you're in the ER, the emergency during a pandemic as a nurse, there's very little you can do for these patients. They were sinking into depression because it was a complete antithesis of what they chose as for their métier, for their chosen role in life. It is tough.
Will you share with us the work that you're doing with women's health? Because we had a particularly emotive conversation about that and how you negotiate with governments to trying to get your work well known.
So this basically started that. We started a company that was focusing on rare diseases and early stage diagnosis because the earlier you can identify these patients, the better treatment you can get for them, and the aim being to give them better quality of life. During one of the validation studies, we identified that menstruation was being underreported or ignored, which is unfortunately a common stigma you see in healthcare. And it's a huge problem because, for some time now, things like ACOGs, the American College of Gynecologists and Obstetricians, have been saying that changes in menstruation should be considered a fifth vital sign. A vital sign being that when a patient shows up for any kind of visit, blood pressure, breathing, body weight, if it's a woman, has there been any change in your menstruation? Because it aligns any change outside of the 28-day cycle is an indication that something has gone wrong, or something is or could be going wrong. And what you've got is about 2,000 years of stigma and prejudice where that's been not really factored into the decision making. What we found with rare diseases is there's very, very specific changes in menstruation that when matched with symptoms, give a good indication this patient has that disease. So we developed the tool, and our objective was let's just give it for free to the OBGYNs, the obstetricians, gynecologists, because after they're doing their normal job, if it's not a frequent disease, it's probably going to be a rare disease. And then you talk to them, and then you talk to your mum, and you talk to your sister, and you talk to your friends, and you realise if you've got a frequent disease, your menstrual changes are totally ignored as well. And it can take, and it's not the fault of the OBGYNs, it's basically how policy filters down to a certain extent, and their own time availability. It shouldn't take 11 years to diagnose endometriosis, for example. It should not be that the default procedure is a hysterectomy because a patient hasn't been managed properly, kind of thing. And nobody wants this kind of thing. So we put together this solution, and I've got a personal bias, favoritism towards resource-constrained settings, specific what they call LMIC countries, so low and middle income countries, so Southeast Asia, Africa, and parts of Latin America. And you go through a process of now we're slowly launching the product into those environments and trying to get traction. And you realise that this is not the only healthcare issue they have to deal with.
Yeah.
And so you're not saying it's quite a clouded environment. I wouldn't say it's crowded or difficult, but it's clouded because there's so many other things going on that they also have to deal with. And then you have to go through the process of trying, like a lot of things in any kind of universal healthcare as opposed to private healthcare setting, is trying to convert any innovation into a solution that integrates into the existing care pathway. So it has to be low budget impact, so no massive training required, no capital investment on new buildings, for example. A classic example of this is magnetic, MRI scans. You'll find in most hospitals, these are running at 24 hours a day. For them to be cost effective, because they're very expensive, and in many cases, you need a dedicated separate building for it because of vibration, otherwise it all goes a bit skewy. To get it cost effective, 24 hours a day. So my dad was recently in hospital, he had an MRI scan at 11:30 at night. It's a case of, so when you have universal healthcare where it's the state that is paying for the healthcare and they've got a limited amount of resource, when you start dealing with the governments and policymakers and regulators, it's a much larger picture you're trying to integrate your solution into. And again, it comes back to the whole ecosystem, empathy with the stakeholders. It's not the only thing they've got to deal with.
Yeah. What kind of official training do you have when it comes to how you negotiate with these different stakeholders?
None.
I mean, it feels like you're kind of going into battle almost like just with your wits and a penknife.
No, I mean, experience. Because we all work together, it's our chosen métier, and we do have empathy for each other. And if you've all decided to align around a common objective, that's what you're going to choose to do.
Yeah.
If you're choosing to do that, then everybody shows up with the right mentality.
So tell me how you've got a room full of different stakeholders. How do you go about finding out what their interests are?
All right, your kick-off meetings are essential. It's
Okay.
like it's not just research and development, I think it's any collaboration. Your kick-off meeting is an opportunity to give everybody 5 minutes to stand up and say, this is who I am, this is the research I've been doing, this is the research and part of my team that I'm bringing into the collaboration, these are my areas of interest. Because these are intellectual people and innovative and they're thinking in 3 dimensions, you don't want to constrain them. The first year is, in most of these projects, is generating these portfolio projects which slowly align based on progress. You match this with training programs, a lot of online meetings, especially for the younger scientists. It's a great way to get them involved by talking to each other, doing what we call journal clubs, so discussing the latest publication or just presenting their latest data. And you slowly build a sense of community and family inside the project. It's no substitute for physical meetings, so you intersperse this with physical training, and we try to have 2 annual meetings, one every 6 months, where you get as many people together as possible, and slowly build this sense of family around a common objective.
Excellent. You know, what I love that I'm hearing you say, and I think when we had our first conversation, you were complaining about something, and I never thought I'd hear you say, you've used the word 3 times, I think, humility, you've used empathy several times. I like also this idea that you slowly do this, because to do it the right way, actually, you have to do it slowly, right? And are you in an industry where things have to happen quickly and you find yourself slowing things down, or is it naturally expected that you can take your time and you can continually iterate and make mistakes?
Because we're regulated, and the evidence requirements of how we can transition from a test tube to a mouse to a large animal model to a human being, and then the different phases of clinical studies, it takes, in most cases for a therapeutic, about 13 years to develop them.
Wow.
Right? If you're doing a diagnostic, 4 to 6, med tech, so things like any device that helps with surgery or this kind of thing, 3 to 4, and now digital health, which is an area I've been working on recently, as we discussed, 15 months.
Wow.
So in the digital health bit, yes, it does go a little bit quicker. We don't go through the same iteration process that you'll see in other IT products, because again, we are regulated of what the outcome is. So it's called software as a medical device, or now AI as a medical device is a separate classification. And depending on what the impact of it on the human will indicate what evidence you need to generate. And that actually applies across any solution you apply to a human being. And if you get into therapeutics, if it's a cardiovascular therapeutic, your phase 3 trials can encompass anything from 350 to 1,000 different people.
Wow.
So,
wow, really?
Depending on it's because what you're looking for is statistical significance. So you have to
Right.
power your study to demonstrate it's actually having the effect you think it's going to have an effect on. Another example of this is your diagnostics, which is your diagnostic thresholds: false positive, false negative, true positive, true negative. You don't want to, it's a dark example, but you don't want to tell a patient they have cancer when they don't have it, and tell them they don't have it when they do. So everything becomes a question of powering. Classic example is in cardiovascular diseases: why can't you predict a heart attack? We did the economic analysis. A single clinical study would probably cost about £15 billion.
Wow.
And to have all the patients over a long enough period of time,
Right.
still with 80% chance of failure. So all the emphasis tends to hinge on, if you've had one heart attack, your risk of having a second one is much higher. So in those patients, you're looking for biomarkers and way to sense them early enough to give an indication that this may be happening to that patient. So everything becomes a factor of impact on human beings.
15 billion to
You
do
need-
a full-scale study.
We figured out,
Wow.
we were approached when I was in a different company by somebody trying to license us a biomarker for predicting heart attacks, and we went away and did the power analysis, and we would have needed something like 2,500 patients over 10 years
Wow.
to be able to say with any level of security that actually that biomarker was relevant.
Wow.
And even then we figured out there was an 80% chance it wouldn't work. And you're going like, this is one of the biggest problems of healthcare. And we talk about iterative process in clinical trials, but at the end of the day, there's still a human being on the other end of it. And there's also one reason, if you look at cancer care, why clinical trials are so short, because the impact is going to be very quick to measure. So they can be a case of it's either having an effect or it's not. And also when you talk to the patients and say, do you want 3 months more of life? Most of them will say yes. So even the effect of the drug or combinations of drugs. So it does vary from area to area that you're working.
Joe, you're not as cynical as you make yourself out to be when you know.
Any more than I am. The coffee hasn't kicked in yet. No, you have to love what you do. I think it's like anything
Yeah.
in life. If you don't love your job, you're doing the wrong job.
Yeah, absolutely. Absolutely.
And yeah, I mean, I'm a bit high energy in the morning. So when I'm awake by 4:30 and I'm already working on the computer by 5 most mornings. Yeah, and I'm in the gym. My brain is going, okay, what next? What next? What next?
Yeah.
And then strange people show up and interrupt your training schedule. And what is the question? No, I mean, I think we're English to a certain extent. I think if you ever read this Richard Lewis, When Cultures Collide. It's a great book on the cliches on business of different cultures and their impact on negotiation. And you read it and think, yeah, we're not like that. But then you sit in a meeting and you realise, well, actually, yeah, we are. And it is the same from culture to culture to culture.
Wow.
And another thing is the importance of language. Learning other languages, especially in business, I think is critical. As when I was in France and was forced to do my presentations in French, my boss told me, if you learn another language, you learn how another group of people think. Your language defines your philosophy and your logic, which means that all of a sudden you've got an extra arrow to look at the problem in a different way, or look at the problem how somebody else looks at that problem, and adapt your own reasoning. So instead of being dogmatic, I mean, this is a classic thing, if you want to delve into Brexit, this may take like another 2 days to discuss this, but it's a case of showing up with, this is what we want, this is the only thing that's going to happen. No human interaction works that way.
Yeah.
And because in healthcare, most of us are international, we go through a process of a postdoc in one country, a postdoc in another, a position in another. We learn empathy in cultures and, pick the best and the worst. And we learn to find ways to work together, accepting differences. There's nothing like being in an international research institute when the Euros are on or the World Cup is on, because everybody comes in with their flag.
Yeah.
You know what I mean? And it's like this a second bit of a way to wind each other up.
Yeah. Yeah.
I mean, I was in Italy when the World Cup and Euros were on. It was just easy discussions to go for each other. But it's a way of finding a way to recognise the human in the other person.
Yeah.
I think it's an essential part of actually
Absolutely. Yeah.
being alive. To be honest, I think we've forgotten that as a skill, and this is one of the reasons why when we start talking about social media in the gym, I tend to go a bit caustic, sarcastic, ballistic because I don't think it is encouraging us to recognise humans.
Yeah, yeah. I mean, you're definitely right. It's. I was listening to something this morning where they were saying that now with children, I think is it the Z generation or is it, I don't, but the latest crop, whatever what label they are, they say that they've grown up now with this literal inability to communicate on the level that we used to. But the cool thing is they're aware of it. Right. So what this study said was they are now aware of it, that they know that they find it challenging to have these conversations, and they're almost asking for help. Right. They almost want to know what can we do? Like, I'm hooked on social media. Right. I'm chasing how many likes I get on Instagram, and I know it's bad for me, but I can't stop. Help. And I think it's the onus is on all of us to work together to kind of create a scenario where, in and of itself, I don't think social media is a bad thing. I think the way we use it is what's really kind of toxic.
Yeah, I think one of the big things is you go out and play together. Find a common hobby.
Yeah.
That doesn't involve an informatic device, as you say. I'm in front of a computer screen every day, all day. Yeah. I can't say, I'm a go all Luddite and hate IT. I'm using it almost perpetually. But to turn it off and go and interact with another human being in a non-confrontational, non-judgmental, end of day, relax, go and do yoga or your sport or stand-up comedy or climbing or art, or just sit on the beach and watch the sunset. Well, you can't, that's the wrong way, but you know what I mean? It's a common sort of do something that involves human interaction as opposed to interacting through a screen.
Yeah. Joe, unfortunately, we've come to the very end of our conversation. I just want to maybe just ask you, could you share, you're not on social media that much, but if somebody listens and they think that guy is really interesting, I'd like to just connect with him, how can they find, and for those people who can't see, there's this look of dread and horror that's just come over. But somebody might just be really interested to follow you and know what you do. How can they contact you or connect with you?
I mean, if you can find me on LinkedIn, I'm good. I mean, I'm on Instagram, but I really go actually look at it. I don't know, LinkedIn is probably the best way to contact me, or go through you, Tony, I think.
Well, we're going to put a link to Joe's LinkedIn profile in the show notes. He's an extremely interesting guy, great conversationalist with a great sense of humor and a real passion for what he does. I'm going to leave you with the sentence that I've written down. I really love what you said about When Cultures Collide, that book. And you said language defines the philosophy and the logic of a people. And I really like that. Joe, I want to thank you so much for joining us on Empathy at the Table. Wasn't that bad, was it?
No, I'm still waiting for the check. But
yeah. Thank you very much for joining us. Talk to you soon. Okay, now. Cheers. Bye-bye.